Thank you very much, Dr. Williams, Mitchell Williams. It really is can you hear me?
Yes.
That's probably the most often expressed sentence on a Zoom call. Can you hear me? But seriously, it's a pleasure. It's really a pleasure to have an opportunity to share. For all the students there, I actually grew up in Camden, went to Camden High School, and where you are now, I used to ride my bicycle with newspapers, throwing them off the bike onto people's porches. Let me see if I can. I don't see my slides.
I did pass the baton to you, so you should be able to push that share button.
Share. There you go. Got it. Can you see them?
Yes, we can see it perfectly.
Wonderful. I really want to thank Dean Riboli and Dean Williams for the opportunity. And I think that the topic is quite important, particularly at this time, the color of law and its impact on health equity. Before we start, I do want to point out that we all are aware that significant number of individuals have died from COVID-19. I'm a microbiologist by training. Globally, there have been over 34 million who have been infected, and 1 million have died. In our country, as you know, 7.2 million have been infected, and over 200,000 have died. Obviously, it's affecting individuals from different neighborhoods and different racial groups. And I certainly am mindful of the fact that our president and his wife have now also been found to be infected, and prayers are with all individuals who are going through this challenge. This is the first class, I believe, of Cooper Medical School of Rowan University. I think each class now is much larger than this one. But as Dr. Williams mentioned, 2016, this class graduated. It was actually the only class that graduated next door to the medical school. It was a somewhat rainy day. The governor was there, and it was just wonderful. I also want to point out with great thanks that I was recognized with an honorary degree at the medical school. The president is conferring it on me here, and my family was there. And growing up in Camden and seeing a medical school on the streets where I used to run around really is very moving to me, and has always been moving to me. Again, thank you, Cooper Medical School, Rowan University, for honoring me. Should also point out that Cooper is doing very well nationally. At the 2019 meeting of the 2019 meeting of AAMC, your medical school, our medical school, received the Spencer Foreman Award. I think you recognize some people in this photograph. It was a beautiful, beautiful evening, and we were very, very proud to participate. Camden is special, and the medical school is special. Your motto, Camden is our classroom, Camden is our home, I talk about all the time. And it's something that you should be really proud of, and I look forward to continuing to work with the medical school. The purpose of the lecture is included here. There are 3 goals I have. What is the 3 questions that I've raised? What is the impact of governmental laws on achieving health equity? And second, what are the political determinants of health? We talk a lot about the social determinants of health. What are the political determinants of health? And how can addressing these issues foster health equity? Issues such as political determinants of health and governmental laws. I have no conflict of interest, and as Dr. Mitchell-Williams noted, I serve on the medical school board. We meet 3 times a year. I'm not sure we're going to be having a lot of meetings in person, but we'll be having Zoom meetings. It's always fun to come back. I want to start with a case study, and this case study, I hope in your small groups you will have a chance to talk about. Jessica is a 19-year-old who has had several miscarriages. Prenatal care is spotty and she missed visits. She gives birth to a 9-week preemie weighing 3 pounds. Jessica almost dies during delivery of heavy postpartum bleeding. In the neonatal intensive care unit, umbilical cord blood samples show numerous toxins. I guess in your discussions, you might consider these questions. How and why did these results occur for Jessica? What were influential circumstances? Where did the system fail Jessica and her baby? What steps can one take to address these challenges? Now, of course, there can be many, many different aspects to Jessica and her circumstances, and that's part of the discussion. We're talking about health equity. I'm sure many of you have probably seen something similar to this, but the question might be, what is the difference between equality and equity? Well, equality, everyone there has a bike. You can see on the top. And then the individual who's in a wheelchair can't use the bike. And you can see how the others don't actually fit the individuals involved. In the case of equity, you're providing what individuals need. You're providing what individuals need. And I'm sure you've heard and learned this, in which case, again, if we look at the 4 individuals, you can see that they're given different types of bikes, but they're given what will allow them to use a bike. So what creates health inequities? Many of you are obviously aware that there are social determinants of health, and often the perception is that poor individual choices and only a lack of access to health care are the key factors when it comes to health inequities. But what we want to do today is to point out that there are historical and current policies that have affected and continue to affect specific communities, environments, access to opportunities, and resources where they can thrive. In other words, policies and laws make have a significant impact. There are some laws that have been actually very helpful in a positive way with regards to the health of African Americans and the underserved. I've listed here 7, and I should point out the PowerPoint will be available. We don't have time to go through all of them. The Hill-Burton Act is something you may not be familiar with, and this was an act in 1946 that allowed for funding for hospitals, and it was quite effective. Brown versus Board of Education of Topeka. I'm not going to tell you about that. If you do not know about Brown versus Board of Education of Topeka, please Google it. The Civil Rights Act of 1964, which made it clear that discrimination was no longer legal. The Voting Rights Act of 1965, the Medicare and Medicaid law of 1965, CHIP, the Children's Health Insurance Program of 1997, and most recently the Patient Protection and Affordable Care Act of 2010. These are just recent laws that have actually been very effective and helpful. The book that I have, there are two books that I will mention in detail. The first is entitled The Color of Law. This is by Richard Rothstein, and it's an excellent book. And as it says on the cover, it discusses a forgotten history of how our government segregated America. The next several slides talk about Richard Rothstein in terms of some quotes that he has shared and also are included in the book. First, he notes something that is really important. Listen to this. Many of our serious national problems either originate with residential segregation or have become intractable because of it. Residential segregation. We have greater political and social conflict because we must add unfamiliarity with fellow citizens of different racial backgrounds to the challenges we confront in resolving legitimate disagreements about public issues. We're unfamiliar with one another. We don't talk to one another. We don't live near each other. And as a result, the challenges and confrontations are obvious. He also points out we have created a caste system in this country, with African Americans largely kept exploited and geographically separate by racially explicit government policies. Although most of these policies are now off the books, they have never been remedied, and their effects endure. Without government's purposeful imposition of racial segregation, if the government had not done this, the other causes of segregation, such as private prejudice, white flight, real estate steering, bank redlining, income differences, and self-segregation, still would have existed, but with far less opportunities for expression. So in the 1940s, the Public Works Administration and the Federal Housing Administration established policies that we're discussing now. The Public Works Administration, housing was primarily designed for whites. This was during and then after the war, World War II. Black housing was segregated, separating African American from white neighborhoods. That was the policy of the government, the PHA. And as far as the Federal Housing Administration was, the FHA, where you get loans to have a home, where your parents probably got support to purchase a home. Bank loans were not allowed to be provided to blacks. Subsidized building subdivisions in suburbs was supported by FHA. Funds were provided for whites to live in new subdivisions in the suburbs. No resale of those houses could be to blacks. It was restricted in the covenants, and subsidized whites to move into the suburbs. So you can see the role that the government had in segregating our country. In the early 1940s, the Homeowners Loan Corporation created residential security maps. So they had maps of cities all over the country. And the steps were taken to routinely deny minority residents access to equal loan and housing opportunities. And this process is known as redlining. It has long-lasting effects on cities that can still be seen nearly 90 years later. The neighborhoods remain as they were intended. So this is a redlining map of Philadelphia, Pennsylvania. And you can see the red refers to the areas where low-income individuals and blacks lived. The yellow and the green and the blue are outside of Philadelphia, and you can see areas where whites were able to live. But the red represents areas where banks were discouraged from providing loans. Of course, this is Camden right here. Surveyors using their Federal Homeowners Loan Corporation received lines on maps and colored some communities red, as you've just seen, deeming them hazardous for bank financing on the basis of race of the applicant. Leading reasons for hazardous, in accordance with the federal government's officials, included the current presence of African American citizens or immigrants. That made the neighborhoods hazardous and not qualified for bank financing. Now this is Camden, where you are going to medical school. Can you see the cursor there? I think you can. This is the Delaware River. And this is where the medical school is. This arrow, see this arrow here? This is where the literally where the medical school is. This is Broadway, and this is where the medical school is. You can see the different areas in Camden that were redlined. Should point out that, again, this is the medical school. This is Haddon Avenue. I'm sure you've been over near Haddon Avenue in the years that you've been there. I actually grew up right here on Langham Avenue in Camden. So you can see the impact of redlining on Camden. Now, if you go down Haddon Avenue, as you know, you can continue to go and you get to Collingswood and Westmont, and you can see that these areas are in the blue. They're areas where a lot of financing was available. And this is Pennsauken. Any of you ever been out to Pennsauken? Yes, and that's where you see these areas are supported by funding. So this represents redlining and the impact that it can have. The housing program was tantamount to a state-sponsored system of segregation. And the third bullet here, African Americans and other people of color were left out of the new suburban communities and pushed instead into urban housing projects. There's a recent paper that actually discusses the impact of redlining on Camden. A newspaper article published in 2018, and I have the link for it on the slide. And Colleen O'Day points out that the following, which is important. There is this reality that even when Black families have the same or higher income as a white family, they still have less wealth because of where their home was located, thus perpetuating the wealth gap. And the second point she makes is that continuing legacy of redlining it's absolutely still occurring today. In fact, she notes 50 years after the Federal Fair Housing Act barred racial discrimination, African Americans and Latinos continue to be routinely denied conventional mortgage loans, etc. And yes, the bottom bullet there, Camden County is one of those metro areas. So what is the impact of redlining on the health of residents? I think that, again, this is a question that you might want to consider in your discussions. I've actually made a slide that shows some of the impacts. Unfortunately, with Zoom, I can't now call on different individuals and say, give me an example, give me an example. I'd like to lecture that way. But what do you think is the impact of redlining on the health of residents? I would buy them because I want you to think about it and give some thought to it, okay? Richard Rothfield makes a very important point that the vestiges of redlining are clear. And what one has to do in addressing them is also clear. He mentions the first bullet, which is in the news today. He says, restore the affirmatively further fair housing, the AFFH, which was initiated under President Obama, that President Trump and Dr. Ben Carson have canceled. This rule encouraged communities to identify and reduce concentrated areas of poverty. He provides 6 bullets in his book, and the last one on the second slide is, I think, important. Listen to the words. Rothstein recommends explore how reparations, housing, and desegregation intertwine. Talk with residents about how best to preserve culture and community while moving towards a solution where one's health is not detrimentally affected by the place where they were born. I'm sure you know that you can often tell the potential of an individual's health. And also when you see patients, you can tell a lot about the zip code of where they live. Someone living in Cherry Hill, whatever that zip code is going to have probably a better health outcome than someone living 2 blocks from the medical school on Benson. Now, the second thing Rothstein points out, and I'll discuss it briefly, is the issue of interstate highways. Some of you may have seen this sign. It's on I-95, and it points out that Camden and New York are in different directions. Now, the point that he makes is actually summarized in a recent paper. The title of the paper says it all. Highway to Inequity, the disparity impact of the interstate highway system on poor and minority communities in American cities. It's written by actually a postdoc at the University of Delaware. It was written by him in 2015. The point that he makes is that in many large cities, interstates have been created, developed as a result of funding from the government, and they cut through neighborhoods. And they do not cut through Belle Meade, they cut through a Black neighborhood or a minority neighborhood or Latino neighborhood. And these are just some of the cities where that has occurred. Tampa, Nashville, Camden, Los Angeles. Some of you are from cities where you can say, oh, yes, there's that highway that goes through, not my neighborhood, but it kind of cut up the city. And of course, you can see it in Camden with I-95, and also the speedway that comes from the south up through Camden to go over to Philadelphia. That speedway cut through the lot where my church was, Kane Avenue Baptist Church. And a report Richard Rothstein refers to, and both these bullets are important. In Camden, I-95 destroyed some 3,000 low-income housing units from 1963 to 1967. That's when Kane Avenue Baptist had to move. And second, the New Jersey State Attorney General Office concluded in a report, and this is telling. In the report, the State Attorney General said, it is obvious from a glance at the transit plans that an attempt is being made to eliminate the Negro and Puerto Rican concentrations by building highways that benefit white suburbanites, facilitating what? Their movement from their suburbs to work and back. Now, the second book that I would like to refer to is just excellent. It's both are excellent, but Daniel Dawes is now a professor at Morehouse School of Medicine. Where is Morehouse School of Medicine? Someone is saying Atlanta. It's one of the 4 historically Black medical schools. And Daniel Dawes is now head of the Satcher Leadership Institute, and he's written 2 books, one on Obamacare, and the other is this one, most recently, The Political Determinants of Health. I actually had a chance to talk with him, telling him I was going to be giving this talk, and he was very helpful. He has presented a slide figure that shows the political determinants of health. And the key ones are voting, governance, and policy. We do not have time to go through this, but you can see the interrelationship between these political determinants of health and commercial interests, housing, engagement, money, demographics when it comes to voting, etc. And I want to comment briefly on the 3, voting, governance, and policy. Voting. In other words, how does voting play into the political determinants of health? I'm sure many of you are well aware of that. Voting is critical, and voting suppression, which is occurring now, really affects who will end up getting into office. For example, and just a couple of days ago, I think yesterday, the governor of Texas said that, okay, yes, we will have mail-in ballots, but there's going to be one depository for these ballots in each county in Texas. So the county where Dallas is going to be one box where you would go and put your ballots. He said that's being done to make sure that the system is fair. And of course, the Democrats are appealing that decision. The second political determinant of health is governance. That is, once individuals are elected, it is very important to let them know how you feel. Advocates must educate, re-educate, and reconnect individuals to their government at all levels and measurably reaffirm that government truly affects the lives of everyone. And the third deals with policies. And we know what policies are, or executive orders are, or incentives are. They can influence individuals. And the second bullet is really worth listening to. Please, advocates should keep in mind, people like yourself, that while success in policies towards health equity may be on the books, there may be laws that say that. There are usually efforts underway to leverage the first 2 political determinants of health, voting and governance, to void the results achieved in the third determination of health by policy. Now, can anyone think of an example where that has actually occurred? ACA, Affordable Care Act. So this was in 2010. That's 10 years ago. So most of you weren't even in high school, am I correct? My God. You're young. This was in 2010, and you can see President Obama and other distinguished individuals signing it. I won't say now what the man who has his arms up, you recognize him? Just before he signed, President Obama signed it, he whispered something in his ear. You can Google that too. It was his expression of how happy he was that it was being signed. So that was in 2010. This is the current map of the state Medicaid expansion decisions. Unfortunately, I live in Tennessee. You can see that Tennessee is one of 18 states that has not adopted Medicaid expansion. In fact, we have 200,000, over 200,000 individuals in Tennessee who have no insurance whatsoever. They're uninsured. New Jersey, obviously, we're proud to say, has, but you can see the states in orange that have not. And you can see your state. So over the last 10 years, there's been a continual effort to try and overturn the ACA or Obamacare. You remember when the late Senator McCain cast a vote that allowed it to continue. Now, the Fifth Circuit Court of Appeals has ruled that Affordable Care Act's individual mandate is unconstitutional, but left it to lower court to decide whether the rest of the health care law should remain. And that decision is being appealed to the United States Supreme Court. It's going to be heard November 10th, a week after the election. And here's a map of the states that are challenging it. The ones again in orange, and then there are others that you can see are defending it or have actually filed amicus briefs defending it and supporting it. So the issue will be, will the ACA's fate be one that will depend on the Supreme Court, and will individuals lose assistance? You can see here, for example, 18.2 million formerly uninsured people would have gained coverage since 2010. 53 million people with pre-existing conditions, and of course, ACA protects pre-existing conditions. 12.7 low-income people in expanded Medicaid programs. 10.6 people who purchased coverage throughout the marketplace, and 5.5 young adults who have gained coverage. So we'll see what happens, and of course that makes the Supreme Court appointment even more important. The political determinants of health. So this is a paper that will be available to you as you begin your discussions in small groups. And it's, I think, a very important paper because it identifies structural racism, some of the points that we've talked about today, social risk factors, and COVID-19, a dangerous convergence for Black Americans. As you know, minorities have been disproportionately affected by COVID-19. Why? What laws have been put in place that have affected them being able to have appropriate, strong health care? What type of jobs are they in? I mean, most of the people on the call can work from home, or at some stage you could work from home. But a bus driver can't. A bus driver going down Broadway can't. And it's interesting that, unfortunately, in New York City, 30, 40 bus drivers died from COVID-19. So it depends on what type of job you're in when it comes to work from home. This paper from the New England Journal of Medicine, July 22nd, 2020, is a good jumping off point for what we have discussed. And in the paper, it's recommended, several things are recommended. Recommended action items for mitigating structural racism. And I'll just note two here. The first, change policies that keep structural racism in place. Break down silos and create cross-sector partnerships. Be consistent in efforts by health systems to build trust in vulnerable communities. And that's a plus to Cooper, because you're interested in working with those communities and identifying ways in which their health can be improved and their healthcare can be improved. But again, this is a paper your small groups will have available. Then Richard Rothstein concludes in his report in his investigations and research 4 important points. We must address the past policies that led to inequities in our system. We've talked about some of those. We must address them. We must fully commit to comprehensively tackling inequities upstream in all areas from education to housing to transportation to employment that are structurally embedded in our society. They're there. Structural racism exists, so we have to address them. We must provide a legally enforceable mechanism to adjudicate such problems. Then finally, and most important, if we do not take these steps, if we say that institutional racism does not exist, structural racism does not exist, it's just a figment of someone's imagination, we will make little progress in keeping the social determinants of health in check. This is a book that has just come out. It's by David Satcher. David Satcher served as the president of Meharry Medical College when I was at Meharry. I was at Meharry Medical College for 19 years. And then Dr. Satcher went to become head of CDC. And then he became Surgeon General and Assistant Secretary for Health. He's a wonderful man. He actually prayed at my wedding, and he prayed at the funeral of my late wife who passed from breast cancer. He always wondered why in the world she married me. But in a serious note, he is just a learned individual, and he loves students. He made this statement, which I hope you remember. You're going to be leaders in the future. Leaders must be good learners, continually learning more about themselves and those they lead. And he tells some stories about where he learned from how to lead by mistakes that he had made. It's an excellent book. And then he says, and he has said it often, we need leaders who care enough, who know enough, who will do enough, and who will persist enough in the efforts to eliminate disparities in health. And I'm sure that you're going to strive to be that type of leader. Care enough, you know enough, you're learning now, you'll do enough, and you'll have the courage to do and speak up sometimes when it might not be easy. And then you'll just persist enough. You'll just keep coming back to make sure that things are improved. I'm going to leave you with a quote from Dr. Lisa Cooper, who's at Johns Hopkins. She's actually a MacArthur Fellow. She's a fantastic scientist. She's a physician, and she's a blessing. And she mentioned in 2018 something that I think is important when it comes to students like yourself. And the process we go through to identify students like yourself who are going to stand up and speak out. And Lisa says, educating and training a diverse group of public health and clinical investigators and practitioners in transdisciplinary methods is important for addressing the health equity crisis. We need people in the field. We need an army. It is particularly important that people from disadvantaged communities cultivate their talents and interests in this work because their personal experiences confer a unique expertise in the realities of developing, implementing, and evaluating health equity interventions. They bring something. Each of you brings something. So the more diverse the class is, the more successful the class will be, and the more successful the medical school will be. And finally, Lisa points out, we believe cross-sector and cross-disciplinary leaders for change in health equity should include professionals with expertise in the appropriate social sectors and academic disciplines, and with value and priorities consonant with social justice. In other words, never forget about justice, because in the final analysis, what we're trying to do is bring social, personal, and health justice to all. Thank you very much. It's my pleasure.
Dr. Hill, you can stop sharing your screen now, or I will stop sharing it for you. So
Okay.
bring you back.
If you can stop, that would be fine.
Great.
Good.
So thank you so much for that great talk. I'm going to open the floor for questions. Students want, or other attendees have questions, you can put something in the chat box, or I can try to unmute you if you want to ask a question directly. I see one question here already, or a statement. Dr. Hill, I thought you were a very powerful public speaker, and I loved your talk. It was the favorite diversity session I've ever attended. I don't have a question, just thank you for your time. So
thank you very much,
Nitesh, for that comment. Really appreciate it. Is there anyone who has a question? Maybe I'll just start with, Dr. Hill, as you know, here at Cooper Medical School, we try to admit students who we think really are a good match to our mission, and that is, service to our community. Do you see ways in which you feel that, as a former Camden resident, our students can really work to address some of these issues that you've discussed today? How can they be best advocates for our community members?
Well, a couple of points come to mind. One is, I think you should be aware of the political systems in Camden and Camden County when they meet. Does the county have regular meetings? What are some of the issues that they're considering? And then when you look at the issues, which ones might affect what you're trying to accomplish? I'll give you an example. When the speed line was being considered, I'm not sure there were a lot of people sitting around the table or meeting with the builders saying this will have this effect or that effect on the population. So being aware of what some of the current issues are and what effect they may have, and then speaking out. There's nothing more powerful to politicians than hearing people who might be voting expressing how they feel. So I think that would be one. The second is, I know you have a great deal of programs that you go out into the community and work. I would not leave out in any way the faith community, because many individuals gain strength from the faith community. They interact with them often. And if there are ways to bring some of those leaders into discussions at the medical school and asking them, well, what do you see missing? And what do you see we can do to help your congregants? I think that would be really positive on both ways.
Great, thank you. And I do have a couple of questions in the chat box now. Katrina asks, I wholeheartedly agree with you regarding the power of learning how to discuss things with one another. I believe that this is critical to make any kind of progress towards healing. It's just moved on me. Sorry, it's flipping around on me. Towards healing and reconciliation. Do you have any ideas of how to facilitate this type of, and then it kind of question went off, but do you have thoughts about that?
Well, actually, in our neighborhood, where I live now, it's a suburban area. And over the last 3-4 months, we've considered this question in some detail. And we decided amongst the individuals who live there, and there are very few Black families that live there. So we had a significant number of people, about 24, of mixed background, race, religion. We came together and started talking, and we read a book. There are several books that are available, and this really revealed to individuals who were not familiar with white privilege or being stopped by the police in a car. You wrote a nice statement on your son. They actually didn't know that even happened. They had no idea, and they were honest. And I think the more we can have discussions like that over book clubs, or another example, I spoke with a synagogue, and that was very, very effective because, again, the leaders wanted to hear and take part in such discussions. So I think if one can actively seek out, I'm sure the medical school group of students in faculty could actively seek out a group in the community that's interested in talking. And that's a challenge for the next year. In fact, it's a challenge where, it could be done via Zoom, or it could be done with, appropriate social distancing. Seek out a group and say, let's learn from one another.
I think that's a great idea. I have another question. This is from Melissa. I lived in Nashville for a few years and volunteered at Meharry. Keeps moving on me because people keep asking questions here. I would be interested to hear how you saw things change, for better or worse, for underserved communities during your time at Meharry. And then she also has another question. Do you feel like there were any major systemic differences between a southern city like Nashville and a northern city like Camden? So 2 questions.
Well, in Nashville, we have no discrimination and no prejudice whatsoever. In Camden, I think you do. So that's an answer to your second question. Again, seriously, Nashville has had many challenges. It still does. Your question really, you need to get a hold of Dr. Satcher's book. If you email me with your address, I'll send you a copy of his book. Because he talks about the challenges that Meharry had in Nashville when they wanted to have the city hospital relocated to Meharry's campus. The city was going to tear it down and build a new hospital like in Pensacola. And the mayor said, and Dr. Satcher, who was the president, said, no, we need to work together to relocate it here to Meharry's campus. And there was a lot of racism that came up, a lot of racism that came up. Fortunately, it was relocated and it's worked out very well. But out of that grew an effort, the Meharry Vanderbilt Alliance, which I was instrumental in working towards. And the 2 institutions who had not partnered very well together are now working together in a wide variety of ways, particularly in helping the underserved receive appropriate health care. So yes, things have improved, things have changed. There's still challenges. One has to keep in mind that Meharry is in North Nashville. I could have shown a red line map of Nashville, but in the interest of time, I did not. and it serves the poor. And you don't make a lot of money serving the poor. Vanderbilt is a world-class, as you know, research institution. Meharry is a world-class education institution. And Vanderbilt has been very successful as a tertiary hospital. But we're working together. I worked at Meharry for 19 years. I worked at Vanderbilt for about 15 years. And the cultures are coming together. But it still requires a tremendous amount of work. And finally, Vanderbilt it's made a lot of progress in terms of race relations within its institution, but we have a long, long way to go.
Great. Thank you, Dr. Hill. We have 3 more questions, and I'm going to try to cut it off at that, see if we can get through these 3 questions. So the first question is a kind of a 2-parter from Javier. Do you see value in creating mandatory racism/bias at all levels of education, med students, residents, fellows, attendings? Part 2 of that is, or based on your opinion, would you think the time would be better served educating the new generations of medical students and having their perspectives influence the senior colleagues when they enter the clinic field?
Yes. And yes, I really do believe that training, discussions, mandatory, however you want to put it, is important and is essential. I'm shaking my head because even in our institution at Vanderbilt now, with such trainings, we still have problems. Unconscious bias is such a major issue that people can say things that are just offensive. One quick example: so one individual left and got a promotion and went to another institution, and they met with the chair and said, "Thank you very much, and I really appreciated being here." And the chair said, "Well, I thought you had really reached your limit here. I'm surprised that you even had the ability to compete in that position." And she shared some thoughts with the chair on her way out. That just shows you, in an institution where our CEO, Jeff Balzer, is just outstanding, we have problems. And I think the only way that can happen is to I think one of the factors that will help is getting that type of individual in the type of sessions that you described. The second part of your question, no. Because you're in a risky situation. You're trying to finish your degree. And I don't think that that's going to be as effective as the institution saying to a department or to a professor, your next paycheck or the incentives that you get are going to be based on the reports we get back on your contributions to health equity in all its dimensions. People respond when it affects their pocketbook.
Agreed. Thank you, Dr. Hill. The next question is from Alex. Alex says, "Thank you so much for the talk today. I personally believe that social equity should not be politicized. Why do you think there is such a divide when talking about these issues, and how can we come to more common," it keeps moving on me, sorry, more common ground?
Well, I think there's a tremendous amount of white fragility in our country. We have never really recognized what was done to my ancestors and Jocelyn's ancestors when they were brought to this country. And we don't want to talk about it. We feel guilty about it. So whenever it comes up, we run from it. And you can see what has happened as we run from it. We're in a really difficult situation in our country right now. So I think we just have to sit down, recognize what has happened, recognize the points that the examples that I've given, and say we have to do something about it. It isn't the reason an individual is living in poverty on Washington Street Avenue or on Broadway is not because there isn't a father in the house. And that's what you see when you read Facebook. It's because of systemic and institutional racism. And we have to recognize it. We have to do something about it. Both Dr. Williams and I could provide you with examples of individuals in our positions, and we've been blessed, still face it. And we have to recognize that that is occurring at all levels, regardless of your training, and we have to address it in such a way that it's effective. I personally think that that's going to happen. I'm optimistic because young people like you are not going to take it anymore. They just aren't, and they just aren't. And we have reached a tipping point, and we have to do something about it.
So, Dr. Hill, we need more conversations. And one of our students, Taylor, says, do you have suggestions for getting across to people who need to participate in these important conversations, but don't show up to the table?
Right. Right. That's always a difficulty. We've had discussions often, and everyone there was on the same page. It goes back to one of the previous questions. We can encourage individuals to come, but then we can require them to come. But then you're going to say, well, yeah, I'm going to come, I'm going to sit there, and I'm going to be blind for the next hour or so. I think that there are ways in which, in small group settings, people can agree that this is going to be an opportunity to not challenge one another in an offensive way, but just to raise points for discussion in a way that one can begin to peel back the unknown and see the individual. I think we found that out in our subdivision. I have found it out in other situations. So I think that can be done. We kind of finish up in our question and answer Q&A with what Rothstein said, but what we all know. We come to work, we work with people, and we go home. We fellowship with people who believe like us. We worship with those type of people. We drink beer with them, those type of people, and we don't know one another at all. And the more we can just take small steps to begin to see that, the better. But we have to, because we can't continue to go the way we are. I mean, one final point is, one might know someone who's Muslim, and you might be Catholic. One might ask them, would you like to come over for dinner? You'd have to get the type of dinner right, but or someone who's Black or brown, and you work with them. Say, well, what are you doing Friday night? My husband and I, my partner and I would be delighted to have you join us for a chat. And that we're going to have to do that because we have to try whatever whatever we can think of in order to try and make it work because we're in a difficult situation.
Thank you, Dr. Hill. And I think, those are some of the things that we're trying to do, this year to try to encourage more of those conversations and, sessions like this and hearing other people, speakers like you, reiterate that is really helpful to us. Brian, one of our other students, was trying to find online David Satcher's book and couldn't see a place to purchase it. Do you have a suggestion? Where did you get yours?
I don't have it. I actually have Daniel Dawes, but I don't have David's. It's published by Johns Hopkins University Press. Actually, both books are published by Johns Hopkins. And I think last night I was looking at for David's, and I think it's on Amazon, but it's I mentioned the title. My Quest for Health Equity, David Satcher.
Okay, we'll look for that. And then a final question here from Wes. Most of the decision makers in this country are not medical professionals. Do you know of existing political infrastructures, lobbying groups that promote physician leaders in government?
I think if you Google the National Medical Association or the American Medical Association, you will find constituent groups associated with both that do what you're referring to. We need more physicians in government in leadership positions. I'm not going to call out any names, but some of them put their medical school to shame. We have an ophthalmologist who is now an infectious disease expert. Then we have a radiologist who is an infectious disease expert. So we need to have individuals who know what they're talking about so they can provide the type of advice that is critical. There are, and David Satcher has a leadership institute at Morehouse School of Medicine. There are leadership institutes that provide the type of guidance that would help in the training of future individuals like what you're describing. In his case, it's called the Satcher Leadership Institute, and now the director of that is Daniel Dawes. I really would encourage that. If I could say one final thing, I know Dr. Fauci. I worked with him. He's an excellent physician. He's a very caring man. And whatever you do, do not take medical advice on infectious diseases from a politician, and do not inject yourself with bleach under any circumstances.
Agree. Well, Dr. Hill, I would like to just thank you again on behalf of Dean Annette Riboli and the faculty, staff, students of Cooper Medical School of Rowan University. Thank you so much for joining us today and delivering this wonderful presentation. We are so appreciative of your ongoing support and for your continued service as a member of our medical school board. Thank you.
Well, thank you, and I look forward to our next board meeting. And for all the students who took the time to participate, thank you very much. I love the institution, and I know you all are going to do very well in your training. And I have to say that Dr. Mitchell Williams is one of the most outstanding individuals committed to medical education, excellence in medical education that I know. She's just super. And the Dean Riboli, and the former Dean, Dean Katz, are the type of leaders that I'm sure some of you are going to be someday. So again, thank you, Jocelyn. You've done a great job. God bless you.
Thank you so much. Thank you all for joining us.